we're going to talk about injuries of the wrist, hand, and fingers. Especially in MSK, I think it's really important to go over anatomy. We'll be going over the osseous, ligamentous, and soft tissue anatomy of the wrist and hand. And then hopefully these topics can be easier to understand and recognize on imaging. The wrist is not a single joint. It is made up of many articulations forming two carpal rows, proximal and distal, as outlined here. So we're going to go over some radiographic things to look at. On the frontal radiograph, we should look at the three carpal arcs, which should be congruent. And on the lateral radiograph, we should look at that collinear relationship of the distal radius, the lunate, and the capitate. And then on that frontal view, that second and third arc, especially that area, that can get a lot of overlap when we have abnormalities. So pay attention to these lines and this alignment. I like to also see that the lunate, which kind of looks like a teacup in my mind, is sitting evenly on that distal radius like a saucer. To ensure that we have a really good lateral radiograph, we need to look at that relationship of the scaphoid, the pisiform, and the capitate. So this is how we can kind of ensure that. The palmar margin of the pisiform should be in the central third of that interval between the capitate and the scaphoid. So on radiographs, you can have kind of a spectrum that is acceptable. So you can see here that the pisiform is in that interval pretty well on both of these radiographs. So these are acceptable laterals that you can trust. These are unacceptable, and I've highlighted the pisiform for you. You can see how this one here is way over, not even within that interval. And this last one here is just hanging over two palmar, so not ones that you can really trust. So going over these measurements and angles in a proper aligned or a proper lateral radiograph, we'll go over some examples of these three types on the lateral view, and then the scapholunate interval here on the frontal view. So that's kind of how we break it apart here. So these angles are based on the long axis of each of these bones. So for example, the scapholunate angle here, you can see the long axis of the lunate and then the long axis of the scaphoid. And normal should be about 30 to 60. And then the capitolunate angle here, you can see that this should really be very low, almost zero, because we talked about that collinear relationship between the distal radius and the lunate and the capitate. So very low numbers there for normals. And then the frontal radiograph, looking at that scapholunate interval. Okay, so let's talk a little more on osseous anatomy and specifically properties of the proximal carpal row. So the bones here in the proximal carpal row are formed and have an inherent properties due to their form and function and morphology. So the proximal carpal row plays a real vital role in proper wrist function and motion to provide that fine motor control that we all have. That ability is part due to this balanced flexion motion here in this first or this proximal row. So the scaphoid is kind of the morphologically, I always think it's kind of top heavy, will want to inherently volar flex or flex palmally or rotate palmally. And then the triquetrum is the opposite. It's designed to flex and rotate dorsally. So this is important for the that real nice kind of coordinated motion that we can all do with our wrist. And so now the lunate gets stuck in the middle, and it is well named. It is called the intercalated segment. And so this balance and motion works very well when the ligaments are intact. Now, when the scapholunate ligament is torn, The lunate is still connected with the triquetrum and will then flex dorsally, producing that dorsal intercalated segment instability pattern. And now that the scaphoid is just not connected at all, it has free rein to really flex forward, and that's how you get this pattern here. How about when the lunotriquetral ligament is torn? The lunate is still connected with the scaphoid and now will flex volarly or towards the palm and forms that volar intercalated segment instability because that lunate tilts volar with the scaphoid. So in the lateral radiographs here, you can see that the lunate that I've highlighted is tilted both dorsally and volarly here in each of those abnormal patterns because of those ligament changes. And then the normal is the lunate is sitting like on a saucer, just like that teacup on the distal radius. So DISI is the most common because it is associated with that scapholunate ligament disruption. So that was an introduction of the osseous anatomy. Let's start the ligamentous anatomy here. There's a lot of them, but I'm hoping to really kind of break it down for you. Dorsally, we just have two to remember. And I use the terms that are in color, but what also makes this complicated is a lot of people call them different things. And so the first is in red there, that dorsal intercarpal ligament. So you can see how that would support those proximal rows, carpal bones in the proximal row and in the midcarpal. And then lastly, the dorsal radiocarpal ligament. And these are the two that you have to keep track of on the dorsal aspect. Now, the volar aspect is a little bit much. It has too many. So for the purposes of this talk and really functionally in MR imaging, we're going to focus on just the top. And we're going to use those top four, and we're going to use this diagram here to help me explain where they are, and then I can show you them on MR. These are the more superficial volar ligaments here of the wrist. And the first two we're going to talk about form this really cool V-shaped structure. You can see how supportive that would be to the carpal bones on the volar aspect. And that is the radioscaphocapitate, a very robust ligament there going from the radius to the capitate, and then the ulnocapitate finishing off that limb heading downward, forming that V shape. And then we have two other ones that are smaller but important, the long radiolunate and then the scaphotrapeziotrapezoid ligament. An intrinsic ligament that we're going to really pay attention to today, talking about scapholunate or scaphoid instability really, is this scapholunate ligament. And we know that there are three portions of this ligament. It is U-shaped, and the dorsal band is the strongest. It can actually can handle up to 260 newtons and is the strongest if you look at the other two. So the scapholunate ligament is the primary stabilizer of the scaphoid and the lunate. And the other ones I just mentioned to you are still important, and that's why I wanted to take some time to show you them and talk about them. These are secondary stabilizers. And you'll come to realize why this labeling them as primary and secondary stabilizers are important. So let me show you these on MR. You can see them. We're going to start with the coronal T2 fat sat and start off dorsally. And as we go through the wrist here, you can see those two dorsal ligaments here. And as we go more dorsal, then we're going to start seeing the components of the scapholunate ligament. And there is the dorsal band, which is taller because it's that upper part of that U. And then the thinner bottom part of that U is the membranous portion, which is described as being triangular there. And then again, the volar band, which is that taller volar aspect in that U-shaped ligament. And as we go more volar, we can see those four that we're going to highlight in this lecture. And that's first that V-shaped configuration of the radioscaphocapitate capitate and the ulnar capitate, and then the two smaller ones, which the long radiolunate parallels that radioscaphocapitate, supporting that scaphoid even more. And then as we go very volar, you'll see the last ligament, which is more like the capsular reinforcement or thickenings of the capsule in that triscaphe joint there. Okay, on the sagittal plane, I really want to take some time because I think this is where you can see the volar ligaments, and I love looking at this on the sagittal plane. So let me highlight that for you. We can see the radial styloid there, and first that radioscaphocapitate ligament. And I look at this on every wrist MR because it acts like a very important strap or seatbelt along the scaphoid. And you can see how that's going to support that scaphoid and have it not volarly flex so much when it is intact. And it goes all the way up to the capitate here, hopscotch, just kind of jumps across those bones. And then now the long radiolunate is just below it, going from the radius to the lunate. If we start from the capitate again, going to the ulnar side, you can see that other limb, that V-shaped configuration. And then lastly, in the axial plane, I think this is really great for looking at those two dorsal ligaments, and mainly that dorsal intercarpal ligament. This is a huge landmark, and I hope now that I've shown it to you, you can pick them up, this ligament up pretty easily. It's this transverse, very linear, distinct, thin membrane or ligament going across from the scaphoid to the triquetrum. So that's the dorsal intercarpal ligament. And again, in the axial plane, you can see the two limbs of the scapholunate ligament, which I like to look at in the axial plane as well, because you can actually cross-section that U-shaped ligament there. Okay, so we've reviewed the osseous and ligamentous anatomy. So let's put that into use. We have frontal and lateral radiographs here. And we're first going to look at that long axis on the lateral view, that long axis of the capitate the lunate and the scaphoid. And you can see that the scapholunate angle is elevated at 73 degrees there. Looking at the frontal view, our lines are not going to be very congruent, especially in that mid-carpal, proximal, and distal row articulation there. So what do we have? And then also the scapholunate interval is a little irregular. You can see that sclerosis. Going back to the lateral projection, I'm going to show you those other angles. You can see that we're kind of in the upper limits, but still normal. The axis of the radius and the lunate are still pretty low. Okay, still looking like that teacup on a saucer. And then the capitate and the lunate relationship is very low as well, almost very collinear. All right, the MR. So that was your plain film. And now the MR, we're going to start volarly. You can see that the volar ligaments, that V-shaped ligament is intact with the radioscaphocapitate and the ulnar capitate. And then as we move more into the wrist, however, now we have even the volar band. We have a little bit of cartilage defect. So the volar band and the cartilage along the scaphoid surface is disrupted there. And as we move more dorsally, the membranous portion is torn. In fact, the whole thing is torn, even the dorsal band. In the axial plane, remember I told you that transverse, you should always see that distinct transverse band. Here, that dorsal intercarpal ligament is not seen, and there is a tear there. And on arthroscopy, you can see there is no ligamentous structures going along that dorsal aspect of the lunate and the scaphoid there. And you can see the MR correlated well because there's that surface of the scaphoid and that cartilage defect. So let's review our findings. We have a complete tear of the scapholunate ligament, both its membranous and dorsal, which is that strongest component, and volar bands. And we have a tear of that dorsal intercarpal ligament, but our volar ligaments are intact. On plain film, we have a widened scapholunate angle, all right, or increased angle, a widened scapholunate interval, but the congruency or the linearity of the capitate, the radius, the lunate, of course, those are all still intact. So what does all that mean? So this is scapholunate dissociation. And we're going to review the stages of the scapholunate instability here. And you can see all those components, all those stabilizers. So this is a spectrum of disease or of pathology. And this is a busy slide. We're going to break this up, but I wanted to kind of throw this at you and why it's important. But how we're going to break it up is management is affected by these stages. So first, the stage 1 and 2, this is treated more conservatively here. So let's go over that. Stage 1 basically will have normal radiographs because that dorsal component of the scapholunate ligament is still intact. It's probably a partial tear from a Fouche injury, and that's why they're tender there. But because the radiographs and all the angles are still normal, that dorsal band is still intact. So it's very important to still look at it on MR so you can tell them, and then they know that this is probably just stage 1, and then they can treat it more conservatively. Stage 2, the next step, it's called the dynamic stage because it needs stress or the dynamic portion. So it needs to have a clenched fist, and this is when you'll only see that interval widen, and that's why it's called the dynamic stage here. Here, the static radiographs are normal, but still means that there is even up to a complete tear that some of that spectrum. But it's an important stage because we need that clenched fist because that'll really help differentiate between stage 1 and 2. And sometimes, depending on the MR, if there's a lot of tearing, there's a lot of pain, they will treat some of these higher grade or more other ligamentous injuries with stage 2 with surgery, but these are generally treated conservatively. Okay. Now, the next stages, these are treated surgically. All right. And stage 3, this was the case that I showed you. What you're going to see here is that there is now tear of both the primary and secondary stabilizing ligaments, where the other 2 stages, it was either one or the other or partial tearing. So you can see that there's a complete tear of the scapholunate ligament, and it might be one of the dorsal or one of the volar, but not both. All right. And, but you will still see the abnormal radiographic findings like widening of the interval here. And then that scaphoid is going to be able to volar or palmar flex, and you're going to see what's called the ring sign or the signet ring sign here because the beam is going straight down the barrel of that scaphoid tubercle and it forms that ring there. Okay. On the lateral view, of course, you'll have an increased angle there of the scapholunate angle. And then stage 4 is just kind of more rotation because now we have both the dorsal and the volar secondary ligaments torn in addition to a complete tear of the scapholunate ligament. So I hope going over these stages helps you apply those anatomic structures, the anatomy that we reviewed. We will also have an enlarged or increased scapholunate angle. You can see how flexed palmarly that scaphoid is. And now we have dorsal tilt of the lunate in stage 4. And this is that disi or that rotatory subluxation of the scaphoid. So I hope that explains that spectrum. The last stage is this now, if you will, just a continuation of the disi, and you'll get, over time, you'll get more degenerative changes of the wrist. So you get that slack wrist, the scapholunate advanced collapse, which initially starts at that radioscaphoid articulation because of the rotation and the ligamentous injury causing that rotation of the scaphoid. And then over time, you'll get more narrowing, more degenerative changes, and then you'll get that proximal migration of the capitate that we're all kind of familiar with in that slack wrist. The treatment for slack wrist is, again, surgical. So knowing those stages are important there from conservative to surgical. And this is sort of the end stage here. And they'll do a proximal row carpectomy and or fusion there of the wrist with dorsal plates there. Okay, We're going to move now to looking at soft tissues. And with soft tissues, I'm going to emphasize some more MR and ultrasound here. And I think ultrasound is a great modality. It's readily available. It's kind of what I do a lot in our practice. And you'll see how you get very up close and personal to these small yet superficial structures with ultrasound. So I wanted to show you and highlight some of that for you. So here's another case. We have a frontal radiograph of the wrist, and you see soft tissue prominence along that radial styloid. A lot of things live there, a lot of etiologies. But what we're going to talk about are tendons, and we know that we have 6 extensor tendon compartments. And along the radial styloid, we have the first extensor tendon compartment with the extensor pollicis brevis there and the abductor pollicis longus. And on MR, you can see that right along the radial styloid, you can see the edema, the synovial hypertrophy, the synovitis in that tendon sheath. So that first extensor compartment with those 2 tendons, along with the extensor retinaculum, form the fibroosseous tunnel. Whenever you have a tunnel, there is constriction and there can be restricted motion. And this is what de Quervain's tenosynovitis is. It is from overuse, where you have tenosynovitis and tendinosis that develop, and it leads to really painful and restriction of movement of the thumb, and that normal glide of the tendons is lost. And I'll show you some cine clips of that. In almost all cases, there is a history of that repetitive, forceful gripping. There's something that's called the baby wrist, where when you hold a baby, your wrist is always flexed and kind of ulnar deviated, and that's what exacerbates that tension on that first extensor tendon compartment. So here we have an ultrasound probe there. It's placed along that the radial styloid, and you can see it's in longitudinal plane there. And what we're looking at is thickening of that extensor retinaculum. You can see how that would entrap the tendons below it in patients with de Quervain's tenosynovitis. Not only is the retinaculum thickened, you can see that the tendon also gets thickened, and then there's synovitis and fluid, so it doesn't glide properly at all. So ultrasound is a great way of evaluating that and telling the orthopedic surgeon or the clinician what's exactly going on, even in function. We can put color Doppler, and you can see that there is a lot of blood flow hyperemia and tenosynovitis there. So there are the 2 tendons in relationship to that fibroosseous tunnel there. Okay, I'm going to show you 2 examples of the first extensor compartment. Do you see any differences? You still see the 2 tendons, but the one highlighted in red, you see a septum. Okay, and so what this septum here creates is 2 subcompartments, and this is important to kind of recognize. And we found that the septum may be absent, it can be complete, and there's a classification system here, or it may even be a partial septum. And anatomically, it's important to note, or if it really is present, because they think the presence of this septum can increase the risk of developing de Quervain's tenosynovitis here. And if you don't recognize the septum and you do an incomplete decompression, there can be failure of injection. There could even be failure of or surgery, and there can even be failure of injection, as if you just injected one compartment here. You can see that we're just in this compartment and we're filling up the fluid here, but we haven't gone through the septum yet. We're almost trying to here in the cine clip, and this compartment has not been reached with all that medicine that you're trying to inject. And so the steroid injection does have a failure rate of 15 to 20%, and it probably is because we're not recognizing the presence of the septum. So here, now what we've done is we've gone through that septum, and you can see now the steroid mixture is going all the way through and around both parts, both subcompartments. All right, now we're going to flip to the flexor tendons. And to describe some of the anatomy first, I want to talk about the zones of the flexor tendons. And our hand surgeons use these zones because it's important for them to communicate where the tear is and where they've retracted to the torn tendon components. So first, zone 1 is just basically from the tip to about the middle phalanx area. In this area, the flexor digitorum profundus, this is the only tendon in the flexor compartment that exists in this distal area. Zone 2, and we're going to talk about this. This is a tricky zone. Lots of things going on here. Zone 2 is basically from that middle phalanx, and that is where the flexor digitorum superficialis tendon inserts. And then it's going to go to about the metacarpal head area. Zone 3 is basically the palm of the hand there, from the metacarpal joint to the start or the end, basically, of the carpal tunnel there, and contains the intrinsic muscles of the hand. Then Zone 5 is the carpal tunnel. Zone 4 is the carpal tunnel, and Zone 5 is the forearm. So the 5 zones there. We're going to focus on that Zone 2 just a little bit. This was once called no man's land because you can see the complex anatomy. It's both the FDP and the FDS, all the pulleys and accessory pulleys there. So this was a difficult repair to do if lacerations occurred in this area, and it had poor outcome as well. So this was, now I think we're doing better, but this is still called that no man's land area, that Zone 2. So why is this important? So if we look at the anatomy a little more, here's an important thing to point out anatomically. At the level of the metacarpal head, the FDS is superficial to the FDP. That's where it gets its name. It's the superficialis there, and the profundus is deep to it. Then past the MCP joint, it splits, and this is where it gets complicated. This is probably my least favorite area to ultrasound. But once I figured out this anatomy, it's really helped me. So it divides into 2 limbs, to the radial and ulnar limb, and then it pretty much just basically continues to separate and dives below the FDP. And the FDS, those 2 limbs, insert on that middle phalanx there. So if we look at it on ultrasound at the metacarpal level, you can see the FDS and the FDP relationship there. And then at the base of the proximal phalanx, you can see that the FDP is lower and now the FDS is split. You see that nice and very zoomed in, really good resolution there and spatial resolution there. And then as we move to the middle phalanx, you can see that the split FDS has now dived below, kind of spiraled below, and inserts onto the middle phalanx, and the FDP is now on top there. And then at the DIP level, we just have the FDP. So on the cine clip, you can see here that from the MCP, you can see that the division, and it's spiraling around and then inserting onto deep to the FDP on the middle phalanx. So here's a case. They can't flex that index finger. And on MR, you can see that there is discontinuity of the FDP just below the DIP joint. However, you can see that at the level of the middle phalanx, the FDS, this is the radial limb, those are intact. So this is a Zone 1 tear of the FDP, and essentially really only the FDP, since that's the only thing that lives in Zone 1. If you took ultrasound transducer here and kind of traveled and looked at the rest of the digit, you can see this really clear and zoomed in. You can see the DIP joint there. You can see the FDP insertion on the distal phalanx is normal, but however, just distal to the DIP joint, you can see an anechoic fluid gap and no tendon fibers. So this is, again, the same patient. So this is a complete tear of the FDP in Zone 1. If we traveled a little more closer to the PIP, the FDS here, you can see that the insertions on each side are still intact. That's why it's still only a zone 1 tear. So our hand surgeons really place a lot of value on these ultrasound exams. Here with this extended field of view, this really helps surgical planning. You can see the torn tendon margins. We can tell them exactly what zone it involves. We can tell them how much retraction there is, and they know how far to kind of make the incision, to dig around and pull it back so they're not kind of, doing it blindly initially. So this is great for preoperative planning. I want to talk about zone 2 before we leave our flexor tendon discussion here. And classic injury when someone is trying to hold something and cut. Don't do that. I've heard of bagels or vegetables. People are cutting and they're holding and something slips and the knife goes down. And the hand is in that flex position. And then when the finger extends, especially when you're trying to do the ultrasound exam, you can see the extent of retraction those tendon fibers undergo there because of when the laceration happened here, and then they open and then they separate. So zone 2, both the FDS and the FDP is torn. All right. And so if we start distally, I always start distally because it's easier. You just have to deal with the FDP and the distal phalanx here. We can see that it is intact. And then as we move down to the proximal phalanx, we can see now that really that skin defect, that soft tissue defect, that is actually the laceration, okay, that obliquely running kind of defect there. And now there's a tear of both the FDP and the FDS tendons. All right, on our last discussion of soft tissue, we're going to dive a little deeper into the carpal tunnel, which is a very common pathology of the wrist. It makes up 90% of all compressive neuropathies in the body, and it's caused by that compression of the median nerve in this fibroosseous tunnel. EMGs are useful, but they're really invasive. They're sometimes not very accurate, and there's false negatives. The other problem with this anatomic area is that there's a wide variation of normal here. My carpal tunnel is a different size than someone that's really tall or bigger. So there is just a lot of biophysical differences, and so it's hard to get a standard. The sensitivity and the specificity of diagnosing carpal tunnel kind of varies widely. Again, it can differ based on those biophysical profiles. Ultrasound can add a lot of value. Here, we're used to looking at the carpal tunnel on MR. You can see the nerve highlighted there on both the STIR and now the T1 weighted sequence. But if we put the ultrasound probe, look at how more zoomed in, I think, a better spatial resolution and contrast resolution. You can see truly that bowing of the flexor retinaculum, which is one of the 3 things I look for. You can see the bones. You can see that line between the pisiform and the scaphoid. And if the flexor retinaculum goes beyond 2 millimeters from that line, there's bowing and there's too much mass effect in that fibroosseous tunnel. And then the third thing is you can actually see flattening of the nerve because it's going under that retinaculum. And you can see proximally and distally, okay, there's the proximal, how that caliber has changed. And so if you see a 2 millimeter difference as it dives under that fibroosseous or within that fibroosseous tunnel, that could be a sign of carpal tunnel syndrome. So I hope you can see how the nerve is a very typical pattern, that multifasciculated honeycomb appearance. You can also do, within that same person, a ratio. So you don't have to worry about the biophysical profiles here person to person, but in the person, you can kind of do a ratio and compare from proximal to distal. And what you want is a ratio that's really 1-to-1 or slightly less than 1, because all nerves should get smaller as we move or go more distal. And here you can see that in the carpal tunnel, we have a 17 millimeter cross cross-sectional area where it was only 8 in the forearm. And so if you see that 2.1 kind of ratio, that's also a sign of carpal tunnel syndrome because it should really be 1-1. Ultrasound is great for looking at post-surgical carpal tunnel releases. You can see that the flexor retinaculum, where it was, you can see the scar tissue in this patient. He had recurrent symptoms, and we thought the reason why is all that scar tissue that has developed because we still saw flattening of that nerve. The cross-sectional area was really increased. I use like 10 to 11 as normal. And again, you can see how distally it is more narrowed and flattened because it's coursing through that area of pressure compared to the proximal nerve. So just something to look at. Other things that can cause compression, going a little bit deeper in anatomy, is the things that surround the nerve. We talked about the flexor retinaculum covering this fibroosseous tunnel here. We also have an epineurium that surrounds the nerve, and then like bursa and synovial tissue that surround the subjacent tendon. But we also have a layer here that can be more echogenic on ultrasound, and that's the subsynovial connective tissue. So if you ever do ultrasound or want to look, and I think people can have variable amounts of this echogenicity, and that can cause compression as well. And I think this is sometimes why our surgeons ask us to inject and kind of do a hydrodissection of the median nerve. You can see the needle coming in, and we've just injected and peeled back all of the structures around the median nerve there, even the flexor retinaculum, using kind of a high volume dose of fluid there as highlighted. So thank you very much. It was a lot of anatomy to go over. We talked about the osseous and ligamentous and soft tissue anatomy and reviewed these pathologies. Thank you very much.